the pelvis of the left side has dropped down. So this is the clue. So which of these structures is involving, or which of the structure is causing this particular problem, that is drooping of the opposite pelvis. So here the patient had difficulty in climbing the stairs when he was made to. So the presenting symptom was he has difficulty in climbing the stairs. What are that abductors? Which abductors, on the right side or the left side, which are acting? Important image where you can understand the lever mechanism, that is the body weight is acting in the center whenever you're putting weight on the two limbs. Hello guys, so welcome to the ASAP batch. I'm Dr. Alekhyha 𝐒𝐿, your orthopedics faculty. So today we are going to deal about orthopedics as a subject. So in this what I have planned for you is I have gone through all the previous year's topic, previous year's questions, and we have brought a set of questions for you, which I think you have already received the question paper. So we are going to solve all this, and we are going to learn in detail about each and every topic, whatever the questions have been asked, and even the options of it. Right, then this would complete actually complete the entire syllabus for you if you concentrate on every option which has been provided for you in the question also. Right, so let's not waste the time, and we'll start off with the first question. This is supposed to be a very important question, and even though it appears to be simple, you can see that this is an integration of the anatomy also with the orthopedics. So let's read the question. So here the patient had difficulty in climbing the stairs when he was made to. So the presenting symptom was he has difficulty in climbing the stairs, but when he was in the OPD on the clinical examination, he was made to bear weight on the right lower limb. Here they specifically mentioned that bearing weight on one limb, that is on the right side. On doing so, the pelvis of the left side has dropped down. So this is the clue. So which of these structures is involving, or which of the structure is causing this particular problem, that is drooping of the opposite pelvis. Right, so hope you all know. And what actually we are talking about? Yes, we are talking about the Trendelenburg sign. So what is a Trendelenburg sign? So let us go into the anatomy of it. Before that, if you have solved this question, put the answer with you, and once we have completed the explanation, we'll go back to the answer again. So now this is what is he has asked. So this is actually the clinical thing which should appear in your mind. So let us assume that this is your right limb on which the patient has put his whole weight, and on that you see that the left side has dropped down. That is what the question was, right? So here what happens is, this is mainly this is actually because of the abductors. So the muscles which are involved here are the abductor muscles. So what are the two abductors of the hip? Very important abductors. So one is your gluteus medius and the gluteus minimus. So for that we have three gluteus muscles: the maximus, the medius and the minimus. So these are considered as the three gluteus muscles, and among these three, the medius and the minimus are considered as the abductors of the hip joint. So what is actually the action of these two muscles? So we already know that they cause abduction, and one more important thing is they will balance the hip whenever you stand on a single limb. So if you're standing on a single limb, like for example, now we are putting the entire weight on the right side. So when you're putting your weight on one limb, these two abductors will take the control of the pelvis and see that there is no tilt in the pelvis. So the action is stabilizing the hip along with your abduction, and the gluteus medius is also involved in the internal rotation also. Okay, and now, so this test, as we already told you, this is called the Trendelenburg test. So as the name suggests, it is called your Trendelenburg test. So what is actually this test? So here what happens is, so when we are standing on the two limbs, the balance or the weight is distributed equally on both the limbs. But when it comes to single stance, that is when we are standing on a single limb, you have to see that the pelvis is maintained. So how is this maintained? This is maintained by your abductors. So we have already learned the abductors, the gluteus medius and the gluteus minimus, right? And now the question here is not that simple. They have stated that the gluteus medius and the minimus Okay, we are sure that there are two abductors, medius and minimus, right? But there are two options which shows that there is medius and a minimus. Now we have to understand what are that abductors, which abductors on the right side or the left side, which are acting. So here what did they tell? The right lower limb, the patient was bearing the weight, and they see that there is a left side dropping down of the pelvis, right? So whenever you stand on one limb, so that particular limb abductors will pull the opposite limb up. That means here the gluteus medius and the minimus of the right side are not acting, hence this opposite pelvis is drooping down, right? So the correct answer would be, very good. So the correct answer would be the gluteus medius and the minimus of the right side. Understood? So pelvis of the opposite side, always remember the opposite dip. The dip is on the opposite side. That means here the right side abductors. So this is your right side abductors, which this right side abductors are not working. Hence you see there is a tilt is on the left side. So this is again an important image where you can understand the lever mechanism. That is, the body weight is acting in the center whenever you're putting weight on the two limbs, right? And then here your neck, that is your femur head plus your neck will act as the fulcrum, right? And then this is the abductors, your gluteus medius. This gluteus medius will act as the power, right? So this act as the fulcrum. So here what you have to remember is this is the load, this is the fulcrum, and this with its power. So when all the three are in balance, you see that the pelvis is maintained in a straight line. But if the body weight is put only on one limb, then this particular side, so if it is on the right side the patient is standing, the right side abductors are to be strong so that they will pull the opposite side hip and make it straight, right? Is that clear for you? So right side, whenever there is a problem, so why actually the problem would result? This result of the problem is because there could be a weakness. So there could be a weakness of this muscles, or there could be damage to the nerve. So what is the nerve supply of this particular muscles? So the nerve supply of this is, yes, it is the superior gluteal nerve. The superior gluteal nerve is the nerve which supplies the gluteus medius and the gluteus minimus. So we have learned so much here. So first, starting right from the anatomy, the abductors are the gluteus medius, gluteus minimus. The action of these two are, they cause the abduction, so they are called the abductors, and then it also causes the stabilization of the pelvis when patient is standing on a single limb, right? And then gluteus medius specifically has one more action which is called as the internal rotation, right? And the sign which is used here is the Trendelenburg sign. So what happens in this Trendelenburg sign? So whenever you try to stand on one limb, the pelvis of the opposite, so you can try it by yourself. You can stand on a single limb and you can see that you can balance the pelvis. It means that the limb on which you're standing will cause the abduction, that is the opposite, raising of the opposite limb, right? So whenever we are standing on the right side of the limb, if your abductors are weak on the right side, it causes the droop or the drop of the pelvis in the opposite hip, right? Just remember, drop, opposite, right? So drop is or dip. Sometimes they even mention it as dip in the opposite pelvis. So whatever is there, you have to remember that this is the on which limb the patient is standing, that particular abductors are affected, hence there will be dip in the opposite side. That is what I want you all to listen and understand. And one more important thing is they ask the nerve supply. So what is the nerve supply? The superior gluteal nerve which supplies this gluteus medius and the gluteus minimus. Then what is gluteus maximus? So gluteus maximus is one more important muscle which is supplied by the inferior gluteal nerve, that is the nerve supply. And what is the action of this? So it causes the extension, and even it causes the external rotation. So this is how you have to derive the topics, right? So this is a important topic which has been frequently asked, but this time we don't know what they might ask. They might ask the nerve supply, they might ask the action, they might ask the sign, or where actually this test is useful. So this is how you derive the subtopics from the previous year's topic question. So we have finished the anatomy related to it. We have finished the clinical examination, that we have understood the Trendelenburg sign and the Trendelenburg test which are used, but which condition will present you these things? So it can be any hip condition such as your TB, arthritis. So whenever there is tuberculosis which results in arthritis, or whenever there is an AVN, also the patient. So these are the clinical conditions where the abductor weakness is seen. So in this particular weakness, when you do this test, the Trendelenburg test, and in case of children, even in case of Perthes disease, you see that this test is positive. So these are certain clinical entities where this test is positive, and this will actually help us for the diagnosis. So we have learned the anatomy, that is gluteus medius and minimus are the abductors, and then we have learned the Trendelenburg test and the Trendelenburg sign, which are the conditions where this is positive. It is positive whenever there is an abductor insufficiency. This could be seen in case of TB, arthritis, in case of avascular necrosis, in case of Perthes disease, or whenever there is a damage to your superior gluteal nerve, right? And then what happens in this Trendelenburg sign, so whenever there is a weakness of this particular abductors, it causes a dip in the opposite pelvis. So that is what you actually see. And then what is the three important gluteus muscles? Maximus, medius and minimus. So we have learned about these two. So the rest is the maximus, which is an important muscle. Okay. And what is the nerve supply of this maximus? So the maximus is supplied by the inferior gluteal nerve. Very, very important, even from the anatomy point of view, right? And then what is the action of this gluteus maximus? It causes the extension and the external rotation. So if even they want to ask you something which is very advanced, like they can ask you about this load, fulcrum and power. So what is the load? The body weight itself acts as the load, if you think this as a lever. And what is the fulcrum? The head and neck act as the fulcrum. And what is the power? The gluteus medius and minimus, the abductors, are acting as the power. So whenever there is a fracture neck of the femur, also this mechanism is disturbed, because the femur, neck and the head acts as the fulcrum, right? So this is the advancement. So what is the least thing which they can ask? They can just ask you what are the abductors, and what is the highest thing they can ask? They can ask you about which is acting as the fulcrum, what is the power, what is the load, right? So this is all about the important question which I have told you. So the answer here would be the gluteus medius and the gluteus minimus of the right side. Hope you all understood it clearly, right? And then we move on to the next one. So the next question is, which is the best investigation for the stress fracture? So what is actually a stress fracture? This you have to remember. So actually, what is actually fracture? When we come to that terms, so let us understand what is actually a fracture. So here I will write. So what is a fracture? So fracture is nothing but it is a breach or the break in the cortex. So whenever there is a breach or the break in the cortex, then there is a loss of continuity of the bone, which is called as fracture, right? And what are the things which is causing this fracture? So fracture is mainly because of the trauma. So whenever there is a force which is acting on the bone, and this bone cannot withstand such forces such as your bending force or twisting force, so then that results in fracture. And what are the other two conditions which you have to remember, where the force is minimal? So here what I want to say is the force is very minimal, and even though when the force is minimal, it can still result in fractures. So what are those important fractures when force is minimal but there is a fracture? So these are the two conditions, that is your stress fracture, and the second one is your pathological fracture. Understood? So one is your stress fracture, the second one is your pathological fracture. So what is the stress fracture? What is the difference between those two? The important difference which you have to remember is, in case of stress fracture, the bone is normal, and in case of pathological fracture, the bone is abnormal. That is, the bone itself is diseased. Hence, even trivial trauma can result in fracture. But in case of stress fracture, but bone is normal. But why the minimal force is also resulting in a fracture? This is because these minimal forces are repetitive. That means if a person is doing an action repetitively which is irritating the bone, it will result in case of your stress fracture, right? So what is the classical example of this stress fracture which is important? So this is called the March fracture. So the March fracture, where you see in the second metatarsal neck, which is called as the March fracture. So one classical example of your stress fracture is your March fracture. So now you see, so where you can identify a fracture here, exactly. So this area where the second metatarsal neck fracture, so this is an example of a stress fracture. Why there is a stress fracture? So what are the points you have to remember? So first one is there is a normal bone. The second point would be the repetitive force which is acting on that particular part will result in fracture. Okay, what are the other examples of the stress fracture? So the first example would be your pars interarticularis fracture. So what is the pars interarticularis? It is a part in your spine, the vertebra, the weakest bone which connects the anterior and posterior. So whenever there is a break in that is also the repetitive force acting on the spine will result in this fracture of the pars interarticularis. So that is one example. And another one is the tibia fracture. So in case of your osteoarthritis, so whenever the patient is not taking care or neglecting the osteoarthritis, initially there will be a varus deformity, and then this might also result in the tibial fracture. Usually the proximal tibia, the junction of the proximal and the medial tibia fractures can be seen in case of osteoarthritis patient, which is also an example of a stress fracture, right? And then sometimes your femur neck. So this femur neck sometimes could be because of the stress, or it could be an example of the pathological fracture also, right? So what you have to remember is these three things: the second metatarsal, the pars interarticularis, the tibial fracture. So these three are very important, which are classical example of your stress fractures. And then comes your pathological fracture. So the pathological fracture is, so we have already learned that the pathological fracture is usually seen in case of your abnormal bone. So what is that abnormality the bone has? So it could be in a condition such as tumors. So it could be whenever there is any metabolic disorders. So tumors condition, metabolic condition, or chronic infections. So these are all the conditions where the bone itself is not normal, hence it is resulting in fracture even with the minimal force. So if you can see this particular x-ray, there you can see there is some lysis around the proximal humerus. So this is the lysis, the bone is not normal. So this is the normal bone, right? So here if you see, the bone itself is not normal, and even you can identify there is a fracture here. So this is a proximal humerus fracture. This proximal humerus, it could be anything. It could be a tumor, a metabolic condition. Here it is a tumor. So you can see some lytic lesion which is there, and then you see a fracture. So this is an example of the pathological fracture. Now, learning so much, what was the question asked? The question asked is investigation of choice in case of stress fracture. So here I have shown you an x-ray for the stress fracture, right? So but usually whenever the fracture is in the initial stage, the marrow is the one which is actually affected, right? So to visualize this particular marrow, so there will be break in the marrow first, followed by the cortex. So to visualize this marrow first, you have to go for which investigations? So it is the MRI. So now we have to learn what are the various investigations or the diagnostic modalities which are present in orthopedics. So the first one is usually what we talk is about the X-rays, right? So usually what we talk about is the X-rays or the radiograph. So in this x-rays, this is a very important tool in the orthopedics. So where you can see bones which are made up of calcium, and they can be seen very clearly, and you can note n number of things, that is about the fracture, about the bone, about the cortex, about the medulla, about its continuity, about its reactions such as the periosteal reaction. So what is the bone doing to the tumor, what is the tumor doing to the bone? So these all things you can learn about the x-rays. But is that really sufficient for every condition in orthopedics? So x-rays are usually sufficient for your fractures, for your metabolic conditions, and in case of tumors, when you want to read about the bone, especially your periosteal reactions. But when you want to read in detail about the bone, because x-ray is just a 2D, two-dimensional image. So you in the x-ray you see the AP and the lateral, and you can see anterior and the posterior. So that is it. So 2 dimensions, one you can see straight, other you can see the sideways, right? So only the 2 dimension. Sometimes is that you think will be sufficient for diagnosing the fracture. For example, I'm talking about the sacral fractures. Will you think the x-ray would be sufficient? Cervical spine, would you think the x-ray would be sufficient? Then we go for something which gives us the 3D image. So what is that thing which gives us the 3D image? So that is your CT scan. So what is CT scan? Whenever there is a computed tomograph. What is computed tomograph? Is the depth. So whenever one more dimension is added to it, that is the 3D dimension, where you can see the length, the breadth, the height of the bone, and you can even comment on the fracture very clearly. Especially it is required in case of your articular fractures, that is the fractures around the joints. So whenever you're talking the fractures around the joints, which are called as articular fractures or the peri-articular fractures. What is the word peri means? Peri means surrounding. So whenever there is a surrounding fracture around the joint, for example, your supracondylar fracture of femur, or your fracture of the elbow, or knee, the proximal tibial fractures. So whenever you want to comment on the joint, whenever the fracture is present even in the joint, that is called the intra-articular extension of the fracture, then you have to go for the CT scan. X-ray would not be sufficient, right? So this is the gross thing which you have to remember, that is the x-rays are mainly used for as the initial tool for any condition, right? As the initial tool. Then based upon that, you have to understand whether we have to read more about the bone. So if you're reading more about the bone, you will go for the CT scan. So remember, C or bone or cortex, C for C. So whenever you want to read for cortex more, that is nothing but the white part you want to read more, then you go for the CT scan. But when you want to read about the soft tissues, so see, we only not deal with the bone all the time. You also deal with the tendons, the muscles, the fascias, what is the extent of the soft tissue around it. So when you want to actually learn about the soft tissues, you go for one more important modality, which is called the magnetic resonance imaging. That is, so these x-rays and CT scan are based upon the radiation. So we are exposed to the radiation in case of x-rays and CT scan. But that is not the case with the MRI. So MRI is mainly based upon the alignment of the protons in your body. It takes the help of the magnetic field, and then the alignment of the protons will result in 2 different images, as you all know, the T1 and the T2 images. So here you can read in depth about the soft tissues, like you can read about the medulla more in case of MRI. So remember, M for medulla, that is MRI, which is M for medulla. Cortex, that is C for CT scan, right? And so whenever you are going for reading of this medulla, if you can see, you have to go for the MRI, and you will see there are 2 important images which are telling you that there is some problem in the tibial shaft in this particular image, which one is T2 and which one is T1. So here what happens is the fat appears bright on the T1, right? So this is your T2 image and this is your T1 image. So roughly I remember this as T1 is mainly to read the anatomy, and if you want to understand about the pathology, like whether there is any collection, effusion, you have to read more about the T2. So T2 tells you about the pathology. So there is some about any inflammation which is present around the part. Then you have to read the T2, and you have to understand abnormal anatomy. Then you have to read about the T1. So these two are the images, and usually what we actually concentrate much on is that you can see there is some abnormality there. So this is the tibial shaft. There is some fracture or there is some defect in the medulla, which could also be a stress fracture, right? So that is how we take help of the MRI, and where all you can read or you can take the help of MRI, especially to understand about the ligaments. So whenever you want to read the ligaments, the tendons, and you want to read about the muscular planes, and mainly you have to understand the spine, we go for MRI, especially the spine, the PIVD, the lumbar canal stenosis, spondylolisthesis, the entire effect of these nerves, whether there is any impingement of these nerves, what is the spinal column, how is it present. So everything we read about the spine. And then ligaments, that is the anterior cruciate ligament, posterior cruciate ligament, all this, the sports medicine entirely, the rotator cuff, all we read a lot of MRIs, right? So spine, sports medicine is where the MRI is used most. In trauma, it is the CT scan which is used most, like the fractures, the dislocations, the periarticular fractures, we all order for the CT scan. So here I have told you that this is the CT scan image. So this is the CT scan. So you can see there is some fracture. Yes, so this is the proximal tibia fracture. So whenever there is involvement of the proximal tibia, matlab the upper part of the tibia, that means it forms the joint, right? So you have to understand about the joint first to treat the fractures around this particular area. So whenever there is a periarticular area, you go for your CT scan, right? So in this you can clearly see the orientation of the bone, right? So whenever you want to read about the soft tissues, you go for the MRI. And the initial tool is always the X-ray, right? So these are the various investigation, diagnostic investigations which are present. And one thing where you go for ultrasound, so there is also ultrasound. So here ultrasound is mainly used as a screening tool for us. So screening of what? So to understand, it is the DDH. If you remember, it is developmental dysplasia of the hip. That is, there is some abnormality in the hip joint during birth or during the development of the baby, where you trace two important angles, the alpha and beta. This is considered as a screening tool for DDH. So here we use the ultrasound. And then the second area where we use it is for the tendon. So for example, there is a break or there is a tear in the Achilles tendon. We first use initially as the ultrasound. So especially for the Achilles tendon, that is the huge tendons, and then it can also be used in conditions such as carpal tunnel syndrome. So in carpal tunnel syndrome also, initial tool we use is the MRI or the decurvence. Decurvence also we use the MRI. So these are the certain conditions where ultrasonography is also used as the tool in diagnosis of certain conditions, right? So these are all the important things which you have to remember, right? So now going back to our question, so I think now you can answer it very easily. So what do you think would be the best investigation for the stress fracture? Yes, the answer here is the MRI. So the answer here is the MRI. So MRI is used. Then when is the bone scan used? So what is the bone scan? So bone scan is where we inject certain material and then we trace that material and find out what is happening inside the bone. So here, whenever there is a single fracture or a unilateral fracture, then you can still go for MRI. But whenever you want to deal with multiple stress fractures or bilateral involvement, then you can go for bone scan. So this is again I told you the advanced version of asking a question. So whenever they ask simply, so what is the best investigation, you undoubtedly mark it as MRI. But if they say there are multiple stress fractures or multiple things which we have to identify, then we usually prefer a bone scan. So CT scan is also preferred, but usually it is the MRI which we usually take. It is the initial condition what we take or what they are asking about. So CT scan is where it is used whenever you want to talk more about the fracture pattern. So you want to understand more about the fracture pattern or the periarticular area. Yes, that is where your CT scan used. Radiograph is also used, but they have asked you the best investigation. So when they ask you what is the initial investigations or the first investigations, then you go for radiograph. But when they ask you the best, it is the MRI, right? So that is how we have learned everything which is present around this question. So this part is very, very important. It will help you to answer more, right? So remember, the fractures can be happen in variety of ways. So the first one is usually the force. Based upon the force, there will be a breach in the cortex, which is called the break or the fracture. But even though minimal forces are applied, there are two important fractures which you have to remember: the stress fracture, the pathological fracture. The stress fracture deals with the normal bone, whereas the pathological fracture deals with the abnormal bone. So whenever the bone is abnormal, this is because the bone is infected, or it is infiltrated with the tumor, or it has some metabolic disorder. What is one important where you see multiple fractures, the metabolic condition? Yes, OI, osteogenesis imperfecta, where you see multiple fractures, right? So you can see multiple fractures. So this is an example of the pathological fracture, right? So what are the examples of stress fracture? The pars interarticularis, the tibial and the femoral neck fracture. So what is the investigations you go for? You go for MRI. And what are the other investigations? So there are x-rays, there are CT scan, there are MRIs. So if there is an anterior cruciate ligament tear, what is the investigations you're going to order? So you go for an MRI. Very good. Whenever there is a periarticular fracture, or there could be a proximal tibia. They just mentioned there is a patient of age 22 years has presented with proximal tibia fracture. What X-ray has shown there is a fracture in the proximal tibia. What is the next investigation you do for the treatment? So the next investigation would be a CT scan, right? So similarly, if they ask multiple stress fracture, what is the investigation of choice? It is the bone scan. But initially, what is the best investigation of stress fracture? It is the MRI. Very good. And ultrasound, the uses of ultrasound in orthopedics. So there are certain conditions. So one is the DDH for alpha and beta angles, and then you have the tendo-Achilles, where because of the tendo-Achilles is very big, right? So on the ultrasound also you can pick up there is a gap or there is a tear, so you can see on the ultrasound. And then there is a carpal tunnel syndrome. You can comment upon the effusion or the if there is any increase in the volume of the contents or decrease in the volume, you can see on the ultrasound for the carpal tunnel. Similarly for the decurvens tenosynovitis. So these are the various examples of your investigations and the diagnostic modalities which can be used in case of orthopedics. Next, go to the second or the probably third question. A child has come to casualty after injuring his left elbow. So whenever there is a child with the elbow, that becomes a very, very important emergency. X-ray was done and found to be case of supracondylar fracture. So we already know whenever there is a child, there is an elbow, the most common fracture which you suspect is always a supracondylar fracture. And when you do commonly correct diagnosis, common diagnosis, you will be commonly correct, right? So usually whenever they say there is a child with the pain in the elbow, first thing you should get in your mind is your supracondylar fracture. So for that you will order an X-ray. Very good. So which of the following complication that can be seen in this fracture? So there is a baby who has had some trauma, and they have taken X-ray, they have presented to you with the supracondylar fracture, and now the mother is worried about what all the complications can we expect in this fracture. So what do you think could be the complications which you can expect in this particular fracture? So for just to understand, so this is the supracondylar area. So the first thing what you have to learn about the supracondylar fracture, which is very, very important, is that it is present around the elbow, but it does not disturb what? It does not disturb the, what is that? 3-point bony relationship. 3-point bony, sorry for the spelling. So 3-point bony relationship. So what is this 3-point bony relationship? So you know that there are 3 important landmarks around the elbow. First would be the medial epicondyle, the lateral epicondyle, and the olecranon. Very good. The tip of the olecranon. So these 3 important bony points together, where they form an isosceles triangle. What do you mean by isosceles? Where the 2 sides are equal, right? So this is called the isosceles triangle. and this is not disturbed in case of your supracondylar fracture. But when it is disturbed when there is a lateral condyle fracture. Or it could be some fracture which is extending into the joint, or intercondylar fracture. Very simple. See, supracondylar is nothing but above the condyles, right? So whenever something is happening above the condyles, obviously the condyles will not be disturbed. Something is happening in between the condyles or around the condyles will be disturbed. Basic sense. But the thing what you have to understand is the terminology, supracondylar. So it is above the condyles. So this is the supracondylar fracture, right? So the first thing you have to remember here in this particular question is your 3-point bony relationship is not disturbed. And then what you have to remember? You have to remember that there is a very, very important complication which can occur with this fracture, that is a damage to the neurovascular structures. So then what are the important neurovascular structures which are present around the supracondylar fracture? So if you see, this is the supracondylar fracture, right? So this is supposed to be the proximal fragment and this is supposed to be the distal fragment. So why usually this particular area is at risk? So this is nothing but the metaphyseal area and this is the transitional area. So transitional area. So whenever there is a transition, for example, let us take an example that soon after you have finished your intermediate, you are entering into your medical school. There will be some particular area, right? For the first initial 1 to 3 months, you will not get adjusted to the environment there. So this is the area which is very vulnerable. Similarly, after completing your MBBS and when you are preparing for a PG, it's also a transition area for you. So whenever something is transiting, for example, here in the bone, it is the epiphysis to diaphysis. That is, the epiphysis is considered to be a cancellous bone, right? And then the diaphysis is the cortical bone, and this metaphysis is the transition from the cancellous to the cortical. So this is supposed to be the weakest part, right? So whenever there is a transition, that is from the little strong to the more stronger bone. So this particular area, especially around 4 to 8 years of age group, that is child of 4 to 8 years of age group, this metaphyseal area is at a vulnerable place where easily it can break. That is this supracondylar fracture humerus, right? So that is what you have to remember, and in this the 3-point bony relationship is maintained. And whenever there is and then what is the classification name for this? This is called the Gartland classification, which is dividing this particular fracture into 3: type A, B and C. So in this, what you have to remember is only remember that the extension type is more common. So what do I mean by extension type? That means I've already explained that whenever there is a fracture, there will be a proximal part and a distal part. The displacement of this particular fracture is only commented based upon the distal fragment. Now the distal fragment is going into extension. So this is the most common type of the supracondylar fracture which we usually see, right? And there is one more called the flexion type, but we usually don't see. We only see this extension type. Extension का मतलब क्या है? You have to remember this: the distal fragment is going into extension, that is going to backward. So what happens? So distal fragment is going backward, the proximal fragment is coming front. This is having something which is called as the spike here, the sharp fragment, and this might damage 2 important structures which are present front of your elbow. So if you see the front of the elbow, there are 2 important structures. What are the 2 important structures you have to remember? The first one is your brachial artery and the second one is your median nerve. The brachial artery and the median nerve are the 2 important structures, but still whenever it goes to the lateral side, there is a damage to the radial nerve as well, right? So you have to remember the most common is these 2, but if it is a displacement which is onto the lateral side, so posterolateral aspect is involved, then it can also damage the radial nerve. And one more important thing is sometimes it damages the branch of the median nerve, which is called the anterior interosseous nerve. So this is all you have to remember. So these are the basing on the displacement what I was talking about. So around the elbow joint, what is very important for us is, first, it is the brachial artery, as I've told you, and brachial artery is in association with the median nerve and its branch, that is the anterior interosseous nerve, right? Sometimes it might also damage the radial nerve on the lateral aspect, or the ulnar nerve on the medial aspect. That is depending upon the displacement, whether the proximal fragment is moving front or back or behind. So that depends upon the displacement. So this is the classical one which I told you. So this proximal fragment is coming forward. So there is always a threat to these two important structures, right? So as I told you, I have told you that the median nerve and the brachial artery are the two important complications which we can expect. So what you will do as the patient arrives to the casualty? So first you will always check the pulse. So checking the pulse is very important, and once you feel the pulse, you have to be happy. And then now what you have to do? You have to try for the treatment. So how do you treat it? So treatment is mainly, so what you do is you reduce it, that is reduction plus casing. Because it is a notorious fracture, you will go for percutaneous pinning. So just reduction, it will not maintain. So what you do is you do this thing what is called as percutaneous pinning. That is nothing but your K wires which are introduced directly from the skin under the C-arm. So what is the C-arm? It is nothing but the radiology. So the X-ray machine which is present inside the theater, it is in the shape of C, hence called the C-arm. And under C-arm you see and you do this cross pinning. So you first reduce the fracture, and then you maintain it with the help of this K wires which are called, and this technique is called the pinning. So as we do from the skin, it is called the percutaneous pinning of the K wires. So this is how you maintain the fracture, and then you apply casing, and after 4 to 6 weeks you try to remove the casing. Because it is a pediatric case, they usually heal early, right? So that is about the supracondylar fracture which you have to remember. So these are all the questions. Every line which I wrote here is a question. So first is the 3-point bony relationship, then what are the other fractures where these relationship is disturbed, that is the intercondylar or the lateral condyle fractures. And then what is the most common type, what is the classification? So classification is Gartland, in that the extension type is most common. And what are the complications? The brachial artery, the median nerve, the anterior interosseous nerve, followed by the radial or the medial ulnar nerve based upon the displacement. And what is the first thing you have to do whenever you see the fracture? You have to always check the pulse. So if the pulse is maintained, you have to reduce it carefully under the C-arm, and then you can do this percutaneous pinning followed by casing. So that is how you treat it. Instead of taking so much of care, it seriously result in complications. So what are those complications which you have to learn? Very important for the supracondylar fracture humerus. So the first complications which we see is mainly the elbow stiffness. So the patient, whenever we present them with the casing, so they present usually with the elbow stiffness, which over a period of time by physiotherapy it gets healed. But what are we worried about? We are worried about the neurovascular complications which we have learnt, the brachial artery, the median nerve, the anterior interosseous nerve. And then there is one more important thing which you have to remember is the alignment. So it results in varus, which is called as the cubitus varus. So this is because when reduction is not proper or on neglecting this supracondylar fracture, this will result in this varus condition. So you can see what is the carrying angle. So carrying angle is nothing but the line drawn along the arm, line drawn along the forearm. If you see, there is some angle which is formed there. But here if you see, this angle is totally disturbed, which is resulting in what is called as cubitus varus, and this is also called as the gun stock deformity, which is seen in case of your supracondylar fracture humerus, right? So cubitus varus, it develops as a late complication. This is because of the rotation of the distal fragment, which is not reduced properly, or in case of neglected supracondylar fractures. You see this condition which is called as cubitus varus or the gun stock deformity. So this is the condition, right? And then what you see is, you also see there would be heterotrophic ossification. So what is heterotrophic ossifications or the myositis ossificans? So what is this? So this is myositis ossificans, is very important question for you. So what happens here is, whenever these people they go for massaging, so in India it is very common that the treatment of a particular individual depends upon the common sense of the parents. For example, if this particular fracture has occurred in any metro city, people are usually brought to the hospital, and whatever we have learned here is done exactly in any hospital by a doctor. But sometimes when this happens in a rural area where there is no specialist available, so they take them to the osteopath. So these are the local persons who are present and who has been treating since ages, but not scientifically. So what they do is, they apply a certain substance and they keep massaging over that particular area. So whenever you massage it, then this particular muscle, which is called as the brachialis, will form calcification, means it undergoes certain changes and it will produce calcium. So this is called as myositis ossificans. Matlab muscle is producing the ossification, that is the calcium, right? So this is called the myositis ossificans. And the important muscle which you have to remember is, here is the brachialis, and this myositis ossificans, most common joint which is involved is the elbow followed by the hip joint. So you have to remember there are two important joints where massage is not at all advised. This is the my elbow, that is the brachialis, and then the hip joint, right? So three important questions. What is myositis ossificans? It is nothing but the muscle converting and stimulating the osteoblast, which produces the bone, that is the calcification. That is the most important thing which you have to remember. Then you have to remember what is the most common joint. The most common joint is your elbow joint, where you see this condition. So what happens, how the patient presents to you? He presents with the restriction of the movements, because what happened is, the brachialis is attached up to here, right, up to your elbow joint, and whenever there is a bone which is present in the joint, the movement does not occur. So there will be a restriction, especially the flexion will be restricted. So the patient cannot eat, cannot comb, cannot do his regular activities. Hence he will come to you because of the restricted activity. And on the x-ray you see there is some ossification in the joint, and that you diagnose it as the heterotrophic ossifications or the myositis ossificans, right? And one thing which you have to remember is one more thing, that is, it should be differentiated from the tumor, right? So sometimes the bone also produces, the tumors also produces the bone. So this is differentiated by the tumor by two important things. One is, in the center you see, so you have to differentiate it from the center and the periphery, right? So what actually is happening here is, in the center you see there is an mature bone, and periphery you see there is an immature bone. So the maturity is from periphery to the center. So whenever you see this mature bone, so that is the trabeculae. Maturity is nothing but the trabeculae, the lamellar bone. Whenever you see this is center, that means it is ready to get operated. Otherwise it is still in the immature part. You have to still wait for the bone to get matured, and then you have to remove that myositis ossificans. So what is the treatment for it? You have to remove it. So the treatment is excision, right? Excision means you have to remove this particular whatever the bones or chunk of the pieces which you can see, so this can be removed. So that is called the myositis ossificans, one of the expected complication which you can see in case of the supracondylar fracture. And then we have the compartment syndrome, right? So we also have the compartment syndrome which can be seen happily in supracondylar fracture, and when you don't treat it, it can result in another dreadful complication which is called the Workman's ischemic contracture. This is the VIC. What is VIC? So the flexor compartments of the muscles gets involved. And what is compartment syndrome? Compartment syndrome is nothing but, yes, so all the muscles in the compartment, they get fibrosed if you don't treat them. So this fibrosis will result in flexion of all these fingers, especially the FDP is involved, FTP is involved. So it will cause flexion of all fingers, right? And this is called the Workman's ischemic contracture. Then what is Workman's sign? So what is Workman's sign? So Workman's sign is, so whenever you want to extend this finger, you will flex the wrist. So you're flexing the wrist, and now slowly the contraction is released and the fingers get extended. Again, on wrist flexion, you see that the fingers go into flexion. So this is VIC, right? On extension, they go into, on wrist flexion the fingers extend, and wrist flexion on wrist extension the fingers flex. It is the reverse thing, okay? So that is the Workman's sign. So on flexion the fingers get relaxed because the length is decreased. That's nothing more scientific reason for it. The only thing is the length of the tendon. So contracture is nothing but there is a shortening of the tendon, right? So whenever you cause a lengthening of the tendon, there will be flexion of the fingers, and whenever you loosen or whenever the distance is decreased, they relax. That's it. That is the Workman's sign. And what is the treatment for that? Treatment for it is, so there is a splint which is called as the turn o buckle splint, which is asked recently in the NEET PG, maybe last year. So the turn o buckle splint is the treatment for the VIC. It is also called as VIC splint. So it is usually, this splint is usually used for putting your fingers in extension. So there is some splint, it is applied like this where you see the fingers in extension. So that is the VIC splint. Understood? Yes, that is called the turn o buckle splint. Okay, now we have completed about the complications. We will go back to the answer and see. Now, happily you can answer. So, what are the complications you see? So, you see there is an injury to the interosseous nerve. Yes. You see cubitus varus. Yes. You see the atrophic ossification. Yes. You don't see cubitus valgus. Then, where you see this cubitus valgus? So, to understand where we see cubitus valgus, we have to go back again to the fractures. So, the fractures, what I told you, the lateral condyle fractures usually, okay. Just excuse me for a minute. So here I've told you varus, right? So why actually the varus occurs? So varus actually is a result of malunion. So what is malunion? Whenever there is union which is present, alignment is damaged. So when the fragments are not united in an alignment, this will result in malunion. So the example of this malunion is your varus, right? So that is the thing which you have to add. In case of complications, the supracondylar fracture will result in malunion. So on malunion, it is the varus which will present to us, right? So here in case of your lateral condylar fracture, what happens is, because this is an intra-articular fracture, this results in the non-union. This is called the non-union. Non-union means, okay, non-union means no union between the fracture fragments. Why is that happening? So this could be various reasons. So the various reasons include the reduction is not proper, there is a lot of gap which is present, or some soft tissue is encountered, or it could be the bone itself is not wanting to unite. So there is some inherent problem in the bone, or there is a vascular supply is lost. So these are multiple reasons which are present for the non-union. So whenever there is a non-union, especially in case of the lateral condylar fracture, this will result in what is called as cubitus valgus. So what you have to remember about the cubitus valgus is one important thing, that is the tardy ulnar nerve palsy. What do you mean by tardy? Tardy matlab lazy, slow. So what happens in this cubitus valgus? So varus, I told you, that is the elbow is moving towards the midline. Valgus, what happens? The hand towards opposite side, that is away from the midline. So whenever something is going away from the midline, what happens is on the medial side. So on the lateral side there is no union. On the medial side there will be union and it will get increased like this, right? So the lateral side it is short, the medial side is stretching. That means it is going into valgus. So this stretch on the medial condyle will cause what? Stretching of the ulnar nerve. But this is not seen instantly after the fracture. It takes many years. So hence it is called as tardy ulnar nerve palsy. So whenever there is a slow stretching of this ulnar nerve, there will be damage to this ulnar nerve which will result in palsy. So this is about your lateral condylar fracture humerus, which you have to remember that it will usually result in non-union. The supracondylar will usually result in malunion. Malunion will result in varus. This non-union, or sometimes the union is there but it is resulting in valgus, right? So that is the cubitus valgus, right? And what is the another thing which you have to remember is the tardy ulnar nerve palsy. So here the 1, 2, 3 is correct, but we don't find an answer which is considering 1, 2, 3. Hence we go for 1 and 2. Sometimes the questions might be asked like this also. So you will not keep on searching for 1, 2, 3. You are sure that 1, 2, 3 is not present, then go for 1 and 2, right? So this is 1 and 2 is the answer. The injury to the interosseous nerve and the cubitus varus are the two important complications which are expected in case of your supracondylar fracture humerus. So that's it of the supracondylar fracture. Moving on to the next one. A father is spinning his child while holding his hands. After a few moments later, the child starts crying and doesn't let anybody touch his arm. What is the probable diagnosis? So I've told you, whenever there is a child with the elbow symptoms, you have to actually think the age of the child. If it is 4 to 8 years, think there is a fracture. Less than 4 years, think about this condition. So what is this condition we are talking about? So here this is a classical thing where the father, who is always the culprit, will keep playing with his son, and this is the posture, pulling off the limbs. So usually fathers are supposed to be, notorious. They do all these gymnastics, right? So while attempting or while playing with this child, he has suddenly pulled his child limbs suddenly forcefully. What happens is the radial head, which is supposed to be present inside the annular ligament, will suddenly pop out of it, right? So whenever this radial head nicely sitting covered around by the annular ligament, so this would be annular ligament and this is your radial head which is sitting, and due to the sudden pull, this radial head will come out of this ligament, and now the patient will have severe pain, right? So the patient will have severe pain, and now he comes with the pronated forearm. So the forearm is in pronation and he comes with severe pain, right? And now what happens is you diagnose it. You take x-ray. Obviously you have to take the x-ray, and on palpation you feel that there is problem in the radial side or the lateral aspect of the elbow. And now what you do? You have to do it immediately. What you do? You flex the elbow and then you do this magic. This is called the supination. So flex the elbow and then supinate it completely. Full supination. What will happen? Now the radial head will come and sit into your annular ligament. The radial head will sit in the annular ligament and immediately the patient will smile. So once the baby is smiling, that means there is a reduction which has happened and now the baby is happy. So this classical scenario which you have to remember, that is the nursemaid's elbow. This is called as the nursemaid's elbow or the pulled elbow. Very important question again. So nursemaid's elbow or the pulled elbow is nothing but the popping of the radial head outside of the annular ligament. This is because while playing or pulling of the child's limb, usually the forearm, which is sudden pulling, that results in this, and the patient comes with severe pain with the pronation. And now what you do, you have to do acts immediately, otherwise it will sometimes itself reduce the pain, right? So this is about the pulled elbow or the nursemaid's elbow, and the treatment, the results are instant. Once you use it, the patient will stop crying. So here I have put up this x-ray also, just to identify whether we are dealing only with the pulled elbow or anything else as they have described, like it could be a ulnar fracture, radial head fracture, or the elbow dislocation always. So for that you have to order or an x-ray always. So what you have to mention in the x-ray, or what you have to actually see on the x-ray, is the first important thing is the anterior humeral line. So whenever this anterior humeral line is drawn, it should usually pass through or cut through the capitulum. So this is the capitulum, right? And this proximal radial line also should pass through the capitulum. This is very important finding. So the important thing is your anterior humeral line passing through the capitulum at any point. It could be extension, flexion, in whatever way you take the x-ray. The important thing is this anterior humeral line should pass through the capitulum. This you have to remember. So you have, this is the capitulum, and this is your supracondyle here. This is the area, and this is your radial head. You have to check for any fractures, and this is your olecranon, and this is the ulna, which is forming the elbow joint. So here, if this is not articulating, this is called as elbow dislocation. And sometimes you see the head is usually, sometimes it is not visible as the age grows. You have to remember, whenever you see radial head, it is by creto, right? So capitulum, radial head, internal, that is your medial epicondyle, trochlea, olecranon on the lateral epicondyle. So based upon the age, you have to identify what are the structures which are present here, and then you have to comment on the x-ray. Understood? So that is about your pulled elbow or the nursemaid's elbow. And after reduction, there is no need to put any cast or something. You can just leave the baby like that. Fine. That is the treatment protocol. Moving on to the next question. An 8-year-old male with painless limb. So here there is a 8-year-old. So now again a pediatric case, 8-year-old male, painless limb and Trendelenburg gait. So we have already learned what is Trendelenburg gait and what is limp. Limp is nothing but that jerk in the movement, right? So whenever you're walking, if there is again a dip in the pelvis, or there is stopping and then walking, it is called as the limp. And on examination, there is a restricted abduction and internal rotation of the right hip. What is the most probable diagnosis? So here what you have, what are the various hints which we have got? So first, there is a painless limp, and then there is a Trendelenburg gait, which is actually so the Trendelenburg sign is there is a dip in the opposite pelvis. What is Trendelenburg gait? The gait is also same as the patient is walking. So what is gait? Gait is nothing but walking pattern. Walking pattern where there are two important stages. So one is called the stance phase. The second is called the swing phase. So stance phase is put the it is like walking like this, right? You walk like this. So one limb you put on the ground, which is called the stance phase. The other limb you lift and you want to put it again in front of this, right? So this pressing of the limb onto the floor is stance phase, while the opposite limb is in the swing phase. So one stance, then the swing, then the stance, then the swing. So those are two important phases. And in this phase, while the patient is putting his limb, if you see there is a dip in the pelvis, that is the opposite pelvis, that means it is nothing but your Trendelenburg gait. Trendelenburg gait, right? So that is the gait. So they have told us that it is a 8 years old, that means a pediatric child with the painless limb. That means there is no pain. She has never complained about the pain, but there is some problem in the hip joint, hence she is presenting with the limp, and the gait is the Trendelenburg gait. And on the examination, they have found out that there is a restricted abduction and the internal rotation of the right hip. So here what happens is mainly, see, let us go through the options. So TB, arthritis of the hip, usually seen in the adults, very rarely seen in the children. So for now, let us exclude it. Septic arthritis, whenever you see, it is painful, right? It is very, very painful, and they will have fever. Congenital dislocation of the hip, again, it could be one of the possibility, right? And then you find this Perthes disease. So usually in congenital dislocation, there is the restricted abduction and the internal rotation of the right hip. It usually not seen because the head is completely absent. So you will find there is exaggerated movements in that particular hip. Now what they are telling us, there is a restricted abduction and the internal rotation, and it perfectly fits in the Perthes disease, right? So what is a Perthes disease? It is a disease which is usually seen in the age group of 4 to 8 years and usually seen boys more than girls, right? And what is this? This is nothing but, it is nothing but the osteochondritis due to vascular supply. What is this osteochondritis due to vascular supply? So what happens is, whenever we are born with certain vascular supply. For example, this is the osteochondritis of what? Of the femoral head. So you see there is osteochondritis of the femoral head. That means the cartilage and the bone which is forming the femoral head is disturbed or inflamed. Why it is inflamed or disturbed? Because of this peculiar vascular supply, especially seen in the age group of 4 to 8 years. So here this is what we are talking about. If you can see the epiphysis, the femoral epiphysis is involved. So whenever the femoral epiphysis is involved, this is called as the Perthes disease. So there are 4 stages in this. So the first stage would be stage of synovitis again, or the inflammation, and then there is a stage of fragmentation, right? And the stage of resolving phase, and the stage of remodeling. So these are the 4 stages. Not to remember all the 4 stages, but why I'm trying to tell you is, so what I'm trying to tell you is, this is a particular phase where actually the it is reversal of that particular pathology. So what happens is, whenever this child who is entering into 4 or 8 years of that particular age group, there will be some disruption in the blood supply. So whenever there is a disruption in the blood supply, it is something which is called as the avascular necrosis, so of the femoral epiphysis. So there will be avascular necrosis of the femoral epiphysis. But as these age is growing, or as the baby is growing, again there will be this blood supply will get into normal, and that is the where the stage gets into remodeling. So this is just the transient phase where you have to be careful. How you will be careful? You will only see that the head is present inside the acetabulum, nothing else you do. So you only see that the head is present into the acetabulum. So whenever there is this Perthes disease which is present, so this is the stage of so and so. So there is a stage of some inflammation, then there will be fragmentation, then there will be remodeling, resolving phase, and then there will be remodeling. So as this phase is passing, every Perthes child will pass all these phases, but you have to identify in synovitis or the fragmentation stage to see that the head or the epiphysis does not subluxate or dislocate from the acetabulum. You have to just put that inside the acetabulum, and the acetabulum will take care. So that is what the head containment surgeries do in case of your Perthes disease. Nothing else. You don't want to treat it. You will not do something to the vascular supply and all. It is self-resolving disease. It is a self-resolving disease. But if you don't put the head back into the acetabulum, this will result in coxa plana, that means complete absence of the femoral head, or sometimes goes up to coxa magna, where the head becomes so big it doesn't fit into the acetabulum, right? So that is what you have to take care about this too. And what you have to remember is, here. So usually we have learned everything, that is, this is the avascular necrosis of the femoral epiphysis, that is the femoral head, AVN 4 to 8 years. Then boys are affected more, it is due to the abnormal vascular supply, and there are 4 stages of this. And head at risk sign, so this has been not yet asked in the exam, so this time we can expect this in NEET PG, that what are the various head at risk sign. That means where you will see that there is some problem with this head and you will take care of that particular patient. So you have to always see for the lateral side of the head. So if there is a lateral epiphysis calcification, or there is a lateral metaphyseal cyst, also there is some cyst which is present in the metaphysis, or there is a gaze or the V sign, that means it is in the shape of V like this on the lateral aspect of the epi and the metaphysis of the head. So this is the gaze or the V sign, which you have to be very, very sure, right? And then or simply lateral subluxation of the head. So these are all the signs. The important one is your again gaze or the V sign, which is present as like this, something like this. So this is actually the fragmented, so like this. So the epi and metaphysis, there will be a damage to that particular side, and you will see this V or the gaze sign there. Okay, so these are all the head at risk sign. And what is this sign? This is also very important. This is called the sagging rope sign. So where this is seen, the sagging rope sign is also seen in case of your Perthes disease. Again, why it is the sagging rope sign? I have told you that head becomes very big, that is the coxa magna. See, this is the big head which you can see, and what happens is this particular part, this is actually the head. So because of this huge size, you see something is dropping like this down. So this is like this. So this is the rope sagging. So you see that skipping rope which you loosely held in between, which causes the sagging. So this is actually the head. So this is actually the head, but on the x-ray it is seen as like this. So this is seen as the sagging rope sign, or is seen in Perthes. The gaze or the V sign is seen in Perthes, right? And what is the treatment? I have told you the treatment is always you go for the x-ray and you see at which stage it is, and you go for the head containment procedure. Head containment procedure. How do you do that? You do it with the varus, that is the proximal femoral varus osteotomy, and if the age is too high, you go for the pelvic osteotomy also. And what is the cast which is used here? This is called the Petrie's cast. So what you do, you put it in abduction. So put both the limbs in abduction so that the head is sitting into the acetabulum. So that is the abduction or the Petrie's cast. So we have done with the Perthes. The important thing is age, and boys are usually seen. It is nothing but the avascular necrosis, but it is resolving. Again, the head get back its vascular supply, and it might grow big or it might not grow also. So there are two possibilities, but what is your duty? To see that head is sitting inside the acetabulum. So what is the most important thing you have to remember? The patient will present with restricted abduction and the internal rotation. So restricted abduction is there and restricted internal rotation, both is there. So why abduction is only restricted? So if you see, there is a problem in the lateral side, right? So whenever something is irritating on the lateral side, the abduction is something which goes like this, opens up. So that means the lateral side should go and touch the head. So here there is a problem in the lateral side, hence there will be a restriction in the abduction and the internal rotation. But most important thing, it is painless. So this is what you have to remember. It is painless with restricted abduction and the internal rotation. So that is about the Perthes disease, right? And then what I want to tell you, one more important thing in case of pediatrics is the SCFE. So what is SCFE? This is slipped capital femoral epiphysis. So here what happens is, usually whenever they want to ask you about the SCFE, they usually present that the person or male is in adolescent age, right? and then it could always be a boy with obesity and with endocrine disorder. So this is actually the qualities of a person with SCIFI. So endocrine disorders, what are the endocrine disorders? So they present with the diabetes mellitus or the hypogonadism. So these are all the things which they present with. So whenever you see there is an adolescent age with the, so what happens here, they only presents with pain in the knee. So this is nothing but a radiating pain from the hip. Radiating pain from the hip. Again, he will have restricted abduction and internal rotation, restriction of the movements. Similarly, of the hip joints, but usually they say there is a pain in the knee joint, and this would be a obesity, like very with high BMI person with the other endocrinal abnormalities like the diabetes mellitus, the hypogonadism. So they present with the pain in the knee, and on the X-ray you see there is a slip of the epiphysis. So the epiphysis slip, right? So this is seen in the X-ray, and now what you do, you fix it. Why? Pinning. So you do percutaneous pinning or just do the K-wire fixation, that is nothing but pinning. So this pinning is called the fixation for the slipped capital femoral epiphysis, the SCIFI, which is usually present with this characteristic. So Perthes is given as this 4 to 8 years age, painless limb. So here it is pain, but sometimes radiating pain they present with knee, and again there will be restriction of the movements. But what is important is this characteristics of adolescent, the male, it is usually the males, and then you have this obesity, the endocrine disorders, like, and what is the important thing they can ask you is opposite. So whether you have to fix the opposite hip or not. So usually in 80% there will be slip of the opposite side also. So hence you do prophylactic fixation. Prophylactic fixation of the opposite side also. So this should be your answer, that we also fix the metachronous slip. So metachronous meaning the opposite side also gets into slip over a period of time. Once you have treated this over 4 or 5 months, he will also present with the opposite side slip. So you will always advise the patient that it is happy that it is easy for you to fix that opposite side also. This is called prophylactic fixation of the opposite side. So this is the scenario for the SCIFI, right? So we have finished the Perthes, then we have finished the SCIFI. These two are very important questions for your NEET PG.